I'd like to invite Sangeet Ghai. He's from the University of Toronto. He's been a leader in the field, a significant amount of publications, and he's a gentleman and a scholar. I'd like to welcome to the stage to talk about prostate MRI. Thank you. Pleasure.
Thank you, Art, for that introduction and your kind words. It's a pleasure to be here today. So this session is more about prostate MR interpretation and just making it easier. I'm going to be talking about, just giving an overview of prostate MRI, and I'll discuss the PIRADS kind of scoring for prostate MR, and then Art, in the second half of this session, is going to show some nice examples and talk perhaps about image quality as well. So when we talk about multi-parametric MR, it includes T2 weighted imaging, which is the morphological assessment of the prostate. It is really the workhorse of prostate MRI. And then you have two functional sequences, diffusion weighted imaging and dynamic contrast enhanced, DCE imaging. DWI, as we know, is the most practical and the most powerful functional tool. And with DCE, we have actually done away with the quantitative and the semi-quantitative kind of assessment. We're only looking at qualitatively, is there focal early enhancement, yes or no. Spectroscopy, of course, as we know, has been dropped from PIRADS version 2.1 in 2019. So multiparametric MRI includes T2, DCE, and diffusion-weighted imaging. So T2 weighted image, as I said, it allows for morphological assessment, and that's because it's got the highest spatial resolution. You can look at the zonal anatomy, peripheral zone versus transition zone. Cancers are generally low signal, but that's a very non-specific sign because prostatitis, hemorrhage, scarring, and fibrosis can also have a low T2 signal. And because of the high spatial resolution, this is the sequence that you're going to be kind of, alluding to for staging as well. So extracapsular extension, involvement of the seminal vesicles. And here, if you look at this image, on the left-hand side, in the left base of this image, there is a low T2 signal. And you can see those finger-like projection extending beyond the prostatic kind of capsule with involvement of the neurovascular bundle. And this is very important information for the surgeons that the patient is going to go to RAT-P. And again, on a coronal image, on a T2 weighted image, you can see the tongue of tissue kind of projecting beyond the capsule. So this is the sequence that you're going to be using for staging. Again, an example of disease extending beyond the capsule. You can see the fuzzy margins in the left base there, and there's involvement of the left neurovascular bundle. So diffusion-weighted imaging, as I said, is a powerful clinical tool. It's probably the most practical and functional technique. It's a method of signal contrast generation based on differences in the Brownian movement. Tumors show restricted diffusion, we know that, but the problem with DWI is it's got low spatial resolution when you compare it to T2 weighted imaging, and it's also prone to motion and susceptibility artifacts, so hip prosthesis, rectal gas can really degrade the quality of your diffusion weighted imaging. And when you're looking at DWI, it's important that you're analyzing the high B value. If you look at PIRADS version 2.1, it mentions that it is mandatory to have a high B value of over 1400. So that's very important. And when you're generating an ADC map, an ADC map actually helps us to quantify the amount of restriction, right? So you put your cursor there, you'll know what is the ADC value. And ADC map should be generated with lower B values, and that's important that your radiologists are following that at your site. It has to be less than 1,000 that you're using for ADC map generation. Otherwise, there's going to be perfusion effect, and you will not get a good kind of correlate between high B value and an ADC map. So lower B values for generating an ADC map, and when you're looking at the diffusion-weighted image, you want to look at over 1,400 and make sure that you're looking at the high B value image. And the higher the B value, the more the diffusion effect. As you can appreciate here, there's a lot of perfusion effect. The higher you go, it suppresses the benign tissue, and it kind of highlights what are the areas that need to be interrogated on diffusion-weighted imaging. So that's the advantage if you're looking at high B value, though your magnet may not allow you to have a B value of over 2,000, and there's going to be some noise as well as you increase the B value. So this is typically what you want to see in a tumor. You should see it, abnormality on the T2s, a kind of focal, encapsulated kind of a lesion, very well defined. And then on the ADC map, you should be seeing a black area or a hyperintense area and a corresponding hyperintense on the high B value. So this is what you're really trying to find on an MR. DCE, it's a series of axial T1 gradient echo sequences. Be sure that you're covering the entire prostate and the seminal vesicles. The temporal resolution ideally should be less than 10 seconds. And what do I mean by that? That every 10 seconds, you should be scanning the prostate. And I'm going to show you an example in the very next slide. The imaging acquisition should be continued for about 2 minutes. And it is scored as either positive or negative. It's kind of binary in our PARADS version 2.1. And a positive score is when you see a focal area of enhancement, it should be enhancing earlier than the rest of the gland. And it should match to an abnormality seen on the other sequences. DCE does not have a role in transition zone, and that's because many benign nodules may enhance as well, early enhancement, so it's really got no role there in PARADS scoring. And it is also a backup sequence, especially when diffusion-weighted imaging may be inadequate or may be degraded. So on the left-hand side here, you have a focal abnormality on the T2-weighted image, and then when I run the cine loop, you can appreciate that as it comes along, you'll see that there is a focal early area of contrast enhancement, much stronger as well, as you can appreciate. So that's what you're looking at on the DCE image, and it should correspond to an abnormality that you're seeing on T2-weighted image as well. So there's a scoring system we have in place on PARADS. There's a separate T2 scoring for the PZ as compared to the transition zone, and I'll show you some examples here. So this would be in the peripheral zone for T2, a score of 1, uniformly hyperintense. Here you see some linear kind of bands, wedge-shaped. This would be a score of 2. These are kind of, somewhat rounded, not circumscribed, moderately hyperintense. This I would give a score of 3 on the T2-weighted image, just a few examples here. And then, of course, these would be 4, right? So circumscribed, quite hyperintense, and very well-defined and focal. These would be, both of them, a score of 4. And then a 5 would be larger than 1.5 centimeters, and if it has an invasive behavior. So here, of course, these are large tumors. There's extension beyond the gland as well. So those would be scored 5 in the peripheral zone. Moving to T2 scoring in the transition zone. So this is kind of, organized chaos. This is normal TZ. This is an encapsulated nodule, which would also be scored as 1. And these changes came on in version 2.1 here, on the PARADS version 2.1. If you see a non-encapsulated nodule or a partially encapsulated nodule, you would say that this is an atypical nodule and give it a score of 2 in the transition zone. A nodule which has got kind of obscured margins would be given a score of 3, and if it does not fit into any other category, so that would be an example of a score of 3, or T2-weighted score in the transition zone. And these would all, again, be obscured kind of nodules. I would give it a score of 3. And of course, a 4 and a 5, this is a typical erased kind of a charcoal. You see one, you know when to call it. And if it's less than 1.5 centimeters, I would give it a score of 4. Sometimes you see those lenticular shaped lesions as well at the anterior margin of the prostate. Those also would classify as a score of 4. But these uniformly kind of hyperintense would be erased charcoal, would be 5 on the right-hand side. When it comes to diffusion-weighted imaging, 1 and 2 are benign as we kind of think of them. A score of 1 is no ADC kind of signal or not a bright signal on diffusion-weighted image. A score of 2 is, again, if you see very linear kind of bands, which may show mild restriction. But I will show you examples of 3 here, and I think that's what's important. That's where many radiologists may get confused. So this I had previously shown as a T2 score of 3 because it's kind of, rounded, moderately hyperintense, and not kind of very well circumscribed. And if you look at it's not probably showing up as well, but there's mild restriction here on the high B value, and there's a mild low signal on the ADC map compared to the adjoining gland. So there's mild on both. It kind of corresponds to an abnormality on the T2. I'd probably give it a score of 3. And the other definition of a 3 is if it is marked in one of the two sequences, so either on the ADC map or on the high B value, but not marked signal change on both, you would still give it a 3. So this is a focal abnormality that you see on T2 weighted image. And then there's kind of marked dark signal on the ADC map, but not very bright on the high B value. So this would again be scored at 3. And this, of course, is a score of 4. It's very dark in the on the ADC map and very bright on the diffusion weighted image. And again, a score of 5 is when it's really dark on the ADC map, and then hyper intense on the high B value. And if it is kind of invasive behavior, is it extending from the peripheral zone to the transition or transition to the peripheral zone, or if it has extracapsular extension. So now that we have looked at different kind of, scores and as per the PARAS version 2.1, there is a dominant sequence for lesions in the peripheral zone and those for in the transition zone. So in the peripheral zone, diffusion weighted imaging is the dominant sequence, and DCE is the secondary sequence for assessing a lesion. And when you look at lesions in the transition zone, we have T2 weighted image as the dominant sequence, and then diffusion weighted image as the secondary sequence. And I'm going to show you a few examples here, but before that, and what's the reason for having a dominant sequence? So as I said, for peripheral zone, diffusion weighted image is the dominant sequence. So whatever score you have for a lesion in the peripheral zone on your DWI is going to be your overall PIRAT score as well. Except if it's a 3, you then look at your secondary sequence in the peripheral zone, which is the DCE, and if it's positive on DCE, you can bump it to a 4. So here's an example that I had shown earlier. So this is more like the surgical capsule right BZA, I would think. So it's a score of 3, perhaps a score of 4, because it's very well defined on T2, but this is the dominant sequence. So here you're going to give a score of 3. And then it gets bumped up to a 4 because the DCE is positive at that site, right? So a score of 3 can be bumped up. This was actually grade group 3 on targeted biopsy. Similarly, the lesion that I had shown earlier, again, a 3 on T2, perhaps very mild restriction, would give it a score of 3. But again, focal enhancement on DCE bumps it from a 3 to a 4. This was a grade group 2 on targeted biopsy. Transition zone for overall PIRAT scoring, one can upgrade. So similarly, T2 weighted image is the dominant sequence. So whatever score you've given on a T2 weighted image is going to be the final overall PIRAT score. But the secondary sequence, which is diffusion weighted image, gives the opportunity to upgrade from 2 to a 3 or from a 3 to a 4. So here's an example of a nodule, which was, I had previously said it's an atypical nodule, probably a score of 2 on T2 weighted image, which is the dominant sequence, but it markedly restricts, right, on both. So it's a score of 4. It's less than 1.5 centimeters. It's not invasive. It's a score of 4. So you're going to bump it from a 2 to a 3. And this was a grade group 2 on targeted biopsy. Another example, this is, previously I've classified this as perhaps a score of 3 on T2 weighted imaging, obscured margins. Again, markedly restricts. It's also more than 1.5 centimeters. So for upping a score from 3 to 4, from upgrading from a 3 to 4, it has to be over 1.5 centimeter and should be restricting as much as it does here. So this was upgraded from 3 to 4, was again a grade group 2 on targeted biopsy. So we've talked about multiparametric MRI, of the 3 sequences. Spectroscopy was dropped way back 5-7 years ago. And we're now moving towards biparametric MR, dropping DCE as well, and just kind of focusing on T2 and diffusion weighted imaging. If you look at PIRAS version 2.1, it addresses but does not endorse biparametric MRI, but since then there have been many studies. And I think the PRIME study results have also come out kind of showing similar accuracy or cancer detection rates on biparametric MRI. So maybe that is, I think, the way forward now. It may be the only way to meet the increased demand of prostate MRI, and there are other advantages like cost, IV access, GAT deposition can be avoided. Thank you.
Excellent talk, thank you. Oh yeah, you might need those. All right, welcome. This is the second part of the session. We're going to shift gears a little bit about interpretation to understanding some of the data associated with it, and when should you order an MRI. I think at this point we all know that an MRI is one of the foundations in risk stratifying patients. No longer do you have an elevated PSA and a prostate nodule leads to biopsies, and this is in every guideline, pretty much in every major country around the world if it's available. I love this picture. This is when Dr. Pinto was early at the NIH. And what threshold do I order an MRI at, if you ask Dr. Pinto? Using the Göteborg study, you really have to take into account there's some age-specific PSA thresholds. At your institution, on your computer, what color is a PSA of 3? Is it red or is it normal? It's still considered normal, but the ACS and the NCCN have recommended a PSA is elevated if it's over 3. And we have language at our institution trying to re-educate our colleagues that use that test to risk stratify patients. They may need to do a further step. I showed this picture this morning every single day, every talk I give. It's important. The 3 studies, A, B, and C, are from 3 different institutions. Those are all 2-2 weighted images. Those images directly impact your understanding of what's happening in the field. If you're fed a certain data set, you're going to have an outcome that's related to that data set, and the poorer quality MRI, you're going to come to conclusions that may not be as the same as another institution with a higher quality scan. This was a study looking at the impact of PI-qual. PI-qual is a way to risk stratify MRIs on quality, and it showed that if you had a PI-qual 1 or 2, which was a poor MRI, the odds ratio was 3.4 in upgrading patients afterwards. This just reinforces the idea that quality matters. And I think it's really important. That's what I'm trying to hit on. Specifically in PI-qual, as well with PI-RADS, you should have your slice thickness on all your scans should be 3 millimeters. They should be cut at the same rate. Occasionally I see places at 4 millimeters for their DWI. That's to make up for the poor signal or the poor quality that the magnet's producing. The field of view is important. You must have a dedicated high B value. We use a B2000, some people use a B2500. It is key and not a calculated one. We've gone back and forth with a calculated versus a raw data acquisition. I think it's really important to get that, use the raw data. Use a DWI, an acquired sequence, not a calculated one. And we've gone back and forth at our institution, and my radiologists have succumbed to my requests. And if you have fat suppression, subtraction, it's mandatory to be used in these sequences for interpretation. I do not think every scan you have to do has to be PI-qual graded. I think it takes too much time. But all of your centers that do it should be PI-qual compliant. And I think that's what's really important is we're talking about quality today for interpretation. Does the multiparametric MRI impact in screening? At both categories, PI-RADS 3 and greater and 4 and greater, the trend is that it helps risk stratify these patients compared to using a systematic biopsy, and we know from all the current data that is absolutely true. And this just reflects the same thing. Another area of research is a biparametric versus a multiparametric for screening. I think everyone needs to understand there's a difference in screening between a diagnostic and a screening MRI, and they serve very different purposes. If you're obtaining a multiparametric MRI before every patient that's undergoing a biopsy, that may be excessive if you have a throughput problem. However, for focal therapy, I believe the DCE is an important sequence, and Sangeet measured the PROMIS data. If Dr. Emberton's here, he's like, we showed equivalence, but he's like, we're not going to give up the DCE. It's very useful to predict what's going to happen after focal, because if you don't have a baseline contrast-enhanced MRI, you're not going to be able to determine if there's residual enhancement of the lesion at the margins if you undertreat it or not. So it's important to make that distinguished or make that point. Also in this paper, it showed there was no difference. However, it only showed there was no difference when they removed the history. So they removed the previous negative biopsy and the patient's history and the risk stratification, then biparametric was able to be equivalent. The precise score. We use this, and I think this is probably the one piece of information that is not utilized at many centers. How many people have a precise score at their institution? I see 2 hands, 3 hands, maybe 4 hands went up. The precise score is basically a way to force your radiology colleagues to be team players. We have multiple MRIs. I sit in clinic and we have clinic prep and we review every single scan that's there. And when they don't have a precise score and they haven't commented on the prior scans, that's a significant lift for myself to review all the scans and determine what is happening. So when they do this, it's wonderful, especially if you trust your radiologist and they've taken the time to assess. Precise 3, no change, 4 a little bit more, and then wow, their 5's a progression of the disease to EPE or something, or metastatic or lymphadenopathy. So it's a really easy way to know what's happening with your patients. I really recommend incorporating that into your workflow. Number 2, the target. There's PIFAB and there's target. Target was a consensus project based out of the UCL group. Sorry, UCL and Imperial was involved too, but I think UCL led it. And they wanted to look at a way to codify what is a failure after focal therapy and how to assess this. PI-RADS does not assess post-radiation or post-focal therapy. It's a risk stratification tool, but it was only designed to predict risk on cancer on biopsy. And the dominant sequence in the target protocol is DCE. Sangeet's going to tell you in his talk maybe tomorrow that DWI does have a role. I've had cases where the DWI is positive, biopsy is negative, the biomarker is negative, but I have also had the converse of that. So it's something to keep in mind. None of these scales are perfect, but to understand if you have residual enhancement, they grade it, and then they use the T2 or the DWI to upgrade your current score as shown here in the schema. This is my favorite one, purr. So, a lot of cats are on the internet these days, so I couldn't resist. But this goes back to, God bless you. I'm trying to cite and discuss the challenges we have with grading an MRI post-radiation. There was a comment this morning, like most of the recurrences that occur in radiation therapy occur in the MRI visible lesion that you had pre-op. I don't think we understand the complete biology of the disease, but it does leave something to question. Are they really treating cancer if the majority of their recurrences occur within the MRI visible lesion that they had before the patient was treated for prostate cancer? Do you see this at your institution? It's pretty consistent. So this is looking at DCE or DWI could be the dominant sequences, all right? A treated prostate that's been radiated shouldn't be enhancing still, right? You have residual tissue. You have something that's still enhancing. And I would tell you during the days of the early CyberKnife, their dose was on the low side. Some prostates look completely normal 6 months after therapy. And we know if we do a biopsy on those, you have to wait at least 2 years for the biopsy to be negative if you're doing focal radiation therapy to a lesion. But this is something that you guys should be aware of, and your radiologist should incorporate this into their workflow, because PI-RADS is not a meaningful risk stratification for it. The remainder of my talk, I'm going to go over 5 cases. Hopefully I'll finish all of them. This is basically to give you an example of a left mid TZA lesion. And this is a 59-year-old gentleman, 2 prior negative biopsies. His PSA is increased up to 7. And with looking quickly, does everyone see the lesion? Raise your hand if you see the lesion. Unbelievable progress. I am very happy. So you see this left TZA lesion. Oops. So you can see this, it's beautiful. This would be a great focal case. Unfortunately, this was early in my career. We just started fusion biopsy. So we're able to sample the area as grade group 3 plus 4. Case number 2. 56-year-old, PSA is 10.4, negative DRE. The prostate volume is 41 cc's. He has a left mid PZPL lesion, grade group 2 on biopsy, 70% max core involvement. We have the lesion on the T2. You can clearly see it. It's organ confined, no signs of EPE. The DWI, high signal, ADC, and focal DCE. I really use the DCE when I plan. Your radiologist might segment and target for the indication for a biopsy, but planning for focal is different. So please remember that. We went over that this morning. This is just an example of how we localize the lesion for focal therapy. We have a planned ablation zone. This was done by hand. This is thank you to Dr. Marquis that helped me prepare the slides for this. And it gives that this is an IRE case. I think it's important, and it really, I believe, helps us understand where the tumor is, where the areas that could be damaged during the process. You can see where we place the probes to be at least 5 millimeters from the rectum, and we're able to perform the treatment. This is roughly our plan and our coverage for the zones that we want to treat during IRE. Unfortunately, sometimes you have a cavity that's formed. This was actually urine that does occur. They're looking to change the format for this. But I show this case because this is something that we see often enough, and the challenge with this is if you do a biopsy of the area, you don't want to cause an infection during the biopsy because you don't want to have this area infected. But to do a biopsy, I usually sample around the outside of the cystic cavity if it's present. This is an example of nanoparticle ablation from one of our earlier trials. After the case, you can see clearly here you have enhancement and lack of enhancement in the proposed treated zone. Interesting enough that the urethra was untouched and the ablation is very close to it. It's based on the nanoparticles absorbing the energy. Same thing, we're just following up the scar tissue, completely ablated. Another case, this is a cryoablation. This patient has 4 years follow-up. He had 4 prior negative biopsies before we diagnosed him. His PSA was 6. Post-treatment, this has been his PSA trend for the last 4 years. The lesion, does everyone see the lesion? Anyone? Yes, Dr. Cianti is like making some hand gestures. This is a large anterior lesion. I think the thing with cryo, you understand that you're pushing energy up. You have to really make sure that your ice travels enough up anterior because you can't visualize through your ice ball to make sure the treatment is successful. 1 year post-biopsy, you have complete contraction, loss of enhancement of space, and that's why I'm saying the DCE, there's still some high signal. He's had 2 biopsies since treatment. There's been no signs of follow-up. And absolutely nothing still. And there's also his PSA really supports the fact that there's probably no signs of recurrence given the large drop in his PSA. Sometimes I believe is a challenge in focal because some lesions, after you treat them, the PSA doesn't drop as much as you expect, but this is definitely related to the amount of tissue that you destroy during the treatment itself. And then is the tumor producing large amounts of PSA. Sometimes we've treated small lesions with really a large drop, and then large lesions don't have the same amount of drop in the PSA, and I have not determined a way to predict this before treatment. Another case, this is from our Vapor 2, just to give you an idea what it looks like post-ablation. Today I'm trying to really just bring you guys full circle. Sangeet went over what things look like and how to score them. I'm showing you a few examples of different ablation modalities to give you an understanding of what that is. All right, we have a left anterior small focal lesion located here, high signal in the DWI, focal enhancement, and you can see the cross axis. It's somewhat clear over here. You can see a focal lesion. I think if you're not looking at the sequences in a 3x2 format where you're seeing multiple sequences at the same time, it's very hard to learn because every time you go and check and scroll back and forth, it makes it challenging to know where you were and where you've been. And at our institution, all slices are at the same thickness. So when you scroll, they're all going to be 3 millimeter cuts that kind of work through the process. Post-ablation, this is a 1 week post-ablation after the catheter is removed. You can clearly see there's absolutely no enhancement in the region. But with the vapor technology, you're taking out a larger portion of the gland, the way the treatment's designed, because you're treating the lesion, medial lesion, above the lesion, inferior lesion, to make sure the whole area is covered without really a lot of added morbidity. We've had patients in the trial and they're doing extremely well. And then post-op 6 months in the follow-up prior to the biopsy, you can see complete contraction of the space without any enhancement. I think all these things are really interesting, but your radiologists need to understand what all these things look like and that they're slightly different, and they have to be able to comment on these. And they should be using the target nomenclature at least as a basic starting point for them to assess. I know other places use Likert. Most of the American College of Radiology has really pushed PIRADS so hard that we don't have any Likert scores anymore, and I was one of the people that fought that tooth and nail in the beginning, but I've come to accept it. But in summary today, PIQUAL highlights the standards for multiparametric MRI, which I went over, which is key. Focal therapy post-ablation should be scored with a target criteria. MR quality matters. Multiparametric MRI and biparametric MRI have utility, but they're not interchangeable. So please remember the difference between a diagnostic test and a screening test. And post-ablation changes vary by the technology employed. And I want to say thank you. And I believe that's the end of our session, correct? We'll do a few questions, I guess.
So, Art, could you comment for a minute on the sequences, specifically for a post-ablation DCE sequence? In other words, the timing, post-injection, at what point the images should be acquired to get to see the early, asymmetric perfusion?
We use this, probably the same thing. He commented in his talk, it's less than 10 seconds. We use 7 seconds at our institution. As you go down, your resolution falls off.
Yeah, so our temporal resolution at our site is about 5.5 seconds, and we kind of keep the same for post-ablation as well. So it's easier for everyone to follow if it's a kind of a single protocol.
So one sequence at 5 seconds?
So you should be scanning for a minimum of 2 minutes. That's what the PIRADS version 2.1 says, and we kind of continue to do that.
Every 5 seconds?
As long, I think, if it's less than 10 sequences, it should be good to differentiate.
Because what you see at a lot of centers is very limited, sequences on DCE. Very limited. They're not.
The whole DCE sequence is only 4 minutes tops, maybe 5. And the only reason people don't want to do it is they don't want to place the IV and pay for the gadolinium because the gadolinium is expensive. But at the end of the day, a diffusion-weighted image sequence is the biggest time sink we have, but it's something that we can't do without. And everything should be the same. Like some places do have a post pelvis and they get a post at I don't know how many seconds, and it's just a disappointment if they don't have a dynamic contrast enhanced MRI.
I think just to reiterate, like post-ablation, DCE is paramount, right? We've got to do it.